So I'm Dr. Brent Monseur. I'm a reproductive endocrinologist. I'm a board certified OBGYN, and I work at Stanford University, where I'm the director of Q+, which is the nation's first academically based clinic that's entirely dedicated to LGBTQ family building. And I'm going to talk a little bit about kind of the clinical aspects of what I do and some of the research that I'm doing. And then maybe rush through a few things so I leave time for questions, and I can always go back to issues if folks want to hear more about that. So just a disclaimer that I always use. I think in the setting of this webinar, maybe people wouldn't attend otherwise, but I do just like to point out that not everybody wants children, and even those people who do want children don't necessarily prioritize a genetic relationship to their future children. But my talk today is really focused on how LGBTQ individuals can use medically assisted reproduction to have genetically related children. So I won't be discussing things like co-parenting, adoption, foster care, or childless living, or any other arrangements that are really no less important. They're just not really the focus of today's talk. So for an overview, I'm going to quickly go over just a history of LGBTQ family building in the United States. Then I'm going to use some examples of some heteronormative assumptions that we might see in the field of reproductive medicine and how we can challenge those norms. I'll talk briefly about my research in sexual minority assigned female at birth, also about some preliminary and some ongoing research in gender minority assigned female at birth. And then also I have some information on sexual minority assigned male at birth. And then I'll talk a little bit about my vision and the future of LGBTQ family building as a field. So in reproduction, we're kind of taught, and we often think about an egg that comes from the ovary of a woman. That same woman has a uterus, and then we have sperm from a man. And I think this is really just kind of the way that medical textbooks are set up. It's the way that society often talks about these issues. And so, I like to kind of bring in from other fields. And so this is a quote from Emily Martin, who was a social cultural anthropologist. And she wrote that culture shapes how biological scientists describe what they discover about the natural world. One clear feminist challenge is to wake up sleeping metaphors, become aware of their implications, and rob them of their power to naturalize our social conventions about gender. And I really like this body of work that she wrote. And it really focused on this idea that reproductive biology is not a fairy tale. And so we often think about, a bunch of sperm that are very masculine, that are competing to get to the egg, and whichever one is the most competitive will win. It's the fastest, it's the best, and kind of giving the sperm a very active role. And the reality is that fertilization doesn't have these like active and passive players in the way that we kind of, make a cartoon version of fertilization. And actually, it's likely that the egg kind of has some kind of ability to bring in certain sperm, and that it's actually more of a union and they're kind of shared participants. So I really just think that we kind of do ourselves a disservice when we put on our gender norms, even on the level of kind of the microscopic level. And so to kind of do a kind of a pun on kind of Judith Butler's work, who wrote Gender Trouble, I often talk about something that I call gamete trouble. So we're kind of like, we think about the sperm and an egg in ways that I don't think are entirely appropriate. And so really reproduction is actually about an egg, a uterus, and a sperm. And it doesn't really matter the identity of the people that that they come from. It doesn't matter their chromosomes or anything else. It just matters if you have these things, and either you can have them, a partner can have them, partners can have them, or you could actually kind of be getting this from a donor or someone else. And I think what's really cool about the field of reproductive medicine is things like in vitro fertilization. And this is a really cool picture of a specific type of fertilization called ICSI, or intracytoplasmic sperm injection. It really highlights how little these identities and these heteronormative assumptions matter, because fertilization can actually take place in a lab. And so we really are kind of divorcing the actual person. And this is really just looking at what you need, an egg and a sperm. So often when I'm seeing patients, I think, a really big key piece is that there's no assumptions. So I can't tell just by looking at someone what gametes they're bringing to the table. And so I often will do what I call kind of a combined sexual or reproductive organ inventory and find out what gametes are available with an individual or with a relationship or with a larger group. And just because someone has those gametes doesn't mean they're planning to use them. So does someone actually want to be a genetic source? If someone has a uterus, do they actually want to use their uterus, or do they just want to be a participant in another way? And so finding out, all the ingredients and how we're going to use them. Just in general, this is an oversimplification, and I'm using identities here just because it's shorthand and it's easier, but I recognize that this is not always the case for everyone. But in general, when we think about lesbian or same-sex egg-producing individuals, we're talking about home or office-based inseminations, or we're talking about something called reciprocal IVF, which would take place in a fertility clinic. Bisexual people are actually really conspicuously absent from the literature, but their options are really going to depend on the situation that they're currently in, which could change over time. For transgender egg producing or other gender diverse individuals, I often talk a lot about egg freezing before, after, or even during gender affirming hormone therapy, which in this case, we're usually talking about testosterone. And for gay or same-sex sperm producing individuals, we're usually talking about a combination of egg donation, gestational carrier, which we colloquially refer to as surrogacy, and in vitro fertilization. For transgender or gender diverse sperm producing individuals, again, kind of talking about sperm freezing before, after, or during gender affirming hormone therapy, which in this case is usually something like spironolactone and estrogen. And there is also a role for specialized urologic procedures. And while I'm not a urologist, I work closely with a reproductive urologist in my clinic. And so we're able to offer some of those procedures as well without the patient having to go to another site. So what are some heteronormative assumptions that we often see? I think a big one, at least historically, was that LGBTQ populations didn't want children. And I think this was actually particularly salient in what we kind of think of as the gay or the same-sex male community. It's like they're only interested in sex and partying, like they don't actually want to have kids. And those are stereotypes that actually still persist today. And we actually see that even in places like San Francisco that were kind of thought to have this history of very storied liberal and acceptance. But the reality is we know this is not true. There are many LGBTQ people that are interested in children. And there's actually a very long-standing history that I don't really have time to go through this in entirety, but I think this is an audience that I probably don't really have to say I'm preaching to the choir, but there has been a lot of negativity about sexual orientation in this country, and people were kind of punished or criminalized or kind of given medical treatment just because of their sexual orientation. There was a concern that sexual deviants, as they were called, anyone who wasn't heterosexual, was actually dangerous to children. And that actually persisted in a lot of different ways for many years. Teachers lost their jobs, people couldn't work in federal jobs. And this really all continued for many decades. And it wasn't really until kind of the 1970s that we started to see things starting to change, where there was kind of lesbian grassroots insemination networks, homosexuality, which is what it was called at the time. Don't typically use that terminology today, but it was removed from the DSM, which was like a textbook of mental health conditions. And so that was really a time that we finally started to see some LGBTQ parents achieving actually the right to have visitation or custody of children that they had maybe in previous heterosexual relationships, but then they lost the right to be a parent because their sexual orientation was found out. I think that, if history had been different, we would have seen a lot of progress continue in the 1980s, because this was a time where IVF was actually starting to be possible. Sperm banks, particularly those in California, started to grant access to single and lesbian women. And also second parent adoption became more commonplace. So this was really kind of the start of what has sometimes been called the first baby boom. And there was a lot of potential here. But then, of course, unfortunately, there was the HIV/AIDS crisis, which really redirected a lot of energy and efforts in the community. And so we kind of didn't see as much progress specifically on LGBTQ family building. But really, kind of coming out of that in the 90s and then into the 2000s, it really galvanized the community to really rally behind this idea of chosen family. And that idea kind of extended to not just the people around you or your partners, but this idea of like, well, we also, part of our chosen family can be choosing to have children. And so really kind of advocating for that to be more legally acceptable, more socially acceptable. And I think now in the modern era, kind of there is now more same-sex marriage equality. There is now a focus on diversity, equity, inclusion. We still have a long way to go, but there are many broad changes that have happened. So the American Society for Reproductive Medicine has really started advocating for access to fertility treatment for all, regardless of marital status and regardless of sexual orientation. So we are moving in the right direction, but I think it is important to just have kind of the historical and clinical context of what's changed over time. Just briefly in terms of demographics, we're a community that historically was not counted, but the census did include for the first time in 2021. And so rough estimate, likely underestimate, about 7% of the US population is LGBT, and about a third of LGBTQ respondents either already have or considering to have children. So, this is all just going back to this idea that really this is a community that has really fought to have children for many years in many different ways, and at least a third have children. So it's really just kind of not true. We know that most patients kind of start their journey, and I think actually Ethan mentioned when they first joined on the call today that, finding information is pretty challenging. Most people, their first step is going to be the internet. And so that's why, Pregnancy Together is great that it's a virtual community, but it can still be hard. And so the reality is that patients shouldn't have to kind of go on a scavenger hunt to find this information. It should really be at the clinic website. This was an older study now that I think we did back in 2016. I can't remember. I was a graduate student at the time. But we looked at the LGBTQ content on fertility clinic websites, and only about half of websites had any content at all. And I'll tell you, when we did this study, we were very generous. So if you had a rainbow flag on there, it counted as LGBTQ content. And so that's not really necessarily helpful. Maybe it might indicate to you that it might be a safer place to go than a place that doesn't have that. Could just be good marketing. But so this is just kind of pointing this out. And this paper actually ended up having a pretty big impact in our community because people were kind of embarrassed that their clinics didn't have this information. So people started to add, even like shortly after this was published, we even had people reach out and say, we think you missed information on our website. And I actually went back and used like the time machine on the Internet Archive, and they actually added it after we were published and then kind of said they added it before. So definitely kind of made some waves after we came out with this. Another heteronormative assumption that we often see is that clinicians use the same regimen that they do for infertile patients. And so I call this kind of the standard therapeutic approach model. And this is really important because I think that we're starting to collect data now for the first time on LGBTQ family building in many different ways. And we're seeing that we might actually be causing harm in certain situations because we're not using culturally appropriate or tailored interventions for the community. We're just kind of doing what we do for everyone else, which, might work, but it might also have these negative side effects or other things to consider. So one thing that I use often as an example is this idea of an insemination. And so the egg is kind of released from the ovary and comes down, and then sperm kind of comes in through the cervix into the uterus, and they meet usually in the tube where fertilization takes place. So, with kind of heterosexual penis and vagina intercourse, the sperm is usually deposited here kind of in the cervix, but with an intrauterine insemination, you can actually use a catheter that's placed into the uterus, and the sperm actually goes and is placed here. And so this is kind of a common technique that's often done. So that was just kind of to provide a little bit of context to one of the first studies that I did as an OBGYN resident when I was at Thomas Jefferson University. And I partnered with EVRMA, which is the world's largest provider of fertility care. And what we looked at was this process called double insemination. And so this is when you do 2 inseminations with donor sperm in the same cycle. So the idea behind this is, right, if someone's infertile, the more sperm you give them, the better. And there is reason to believe that physiologically, this might actually help individuals that are infertile, maybe due to kind of low sperm counts and they're having heterosexual intercourse. But there isn't a lot of biological plausibility as to why that would help someone who just needed sperm exposures at the right time. But this was an example of where we found that in about 1,000 cycles in lesbian and single individuals, almost 90% of them were this double variant. And, when you tell a heterosexual couple that we're going to do in a double insemination, it just means that the partner needs to come in and ejaculate in a cup one more time. So, that can be awkward, but it's not entirely that burdensome. But when you ask a lesbian or a single patient to do that, you're essentially asking them to pay another $1,000 at the bank for another vial. And so I was really interested in this idea of, well, we don't really expect this to have a difference, but we're making people pay an extra $1,000. And if you have to, on average, do 4 to 5 inseminations to be successful, that means on average, we're asking people to pay $5,000 extra for what benefit? And so we actually showed that there was only less than a 2% difference in clinical pregnancy. And I can tell you that that's not a difference that I think is worth $5,000, or really a difference that is statistically significant. And so this just kind of shows you here graphically that there really isn't a difference. And so this was a way that we were kind of changing the practice. And so now this is no longer done. They no longer are doing double inseminations for folks that really just don't need it. Another example of kind of, there are ways that we can do care differently if an individual has a partner and they both, for example, if they both produce eggs, they both have a uterus, you can do something called reciprocal IVF. So with classical IVF, you usually get the eggs from one person, you make embryos in the lab, and then you transfer that embryo back into that first person. But with reciprocal IVF, you can actually do an egg retrieval on one person, make embryos in the lab, and do the embryo transfer on another. So, sure, this is, but what does that mean? Well, I think what's important here is that because this is a different way to kind of build your family, it's important that we also study the outcomes of doing it this way. So people started offering this, which I think is great, but we also have to make sure that the success rates are also going to be good. So we actually, I partnered with one of the fertility doctors who at the time was in Spain, but he now has a practice in Portugal. And so he actually kind of pulled data from several clinics in Europe to look to see about the success rates of, it can be called reciprocal IVF or shared IVF. In Spain, it's called ROPA, or reception of oocytes from the partner. And we showed that there was actually good oocyte yield, good fertilization, and good embryo development. And also the live birth rates per transfer were about 45% on an individual level. And then they were also analyzed at the level of a couple, which is a way that we don't usually present data in heterosexual folks because only one person can be pregnant typically in that situation. So we really kind of just showed this is a successful approach. And so it is something that we can feel comfortable offering. And so that was really great and reassuring. Another heterosexual assumption or heteronormative assumption that we see is that clinicians might overlook risk factors that might exacerbate negative effects downstream. And so this idea that, oh, it's kind of the flip of kind of the assumption number 2. So instead of saying, oh, we're going to do the same approach for everyone, you might say, oh, this is a lesbian couple. I don't worry about those patients because they're not infertile. And so I can do whatever and they'll be successful. And so, not really thinking very cautiously about, well, what if it's someone who actually does have risk factors? The reality is that we know that there are health access barriers that can result in delaying time to care, which might actually mean that you might not see an LGBTQ patient until maybe 5, 6, 7, or 10 years after they really wanted to see you because they couldn't afford to come to see you before. And so they might have more issues because they waited. They might be more likely to have poor preconception health. There are certain things that we see in the literature that are more common among sexual and gender minorities that we just have to be aware of. And, this is a process of using donor material. There's more risk involved when you're using a specimen that is not a specimen from an intimate partner. And I've already kind of mentioned this, there's really just a lack of guidelines. And a lack of guidelines means it's not standardized and it's also usually not tracked. So what are the impacts of exposure to gender-affirming hormone therapy? What about the practice of putting back more than one embryo for those same-sex male couples that can only afford to do it once, but then it results in the surrogate having twins, triplets, or even more? And then, as we kind of already talked about, what about inseminations that aren't kind of done? Like, you don't need to do two, or do you really need to use medicine when you do an insemination with someone who's not infertile? And we actually know from internal data that we looked at Stanford and UCSF, about half of the inseminations in lesbian patients actually used medication for their insemination when you really wouldn't physiologically kind of think that they would need that medicine. And so we actually did a study looking at state data in California. And we actually showed that medically assisted reproduction was about 16 times higher in sexual minority women. I'm using the terminology women because that's the terminology that we use for this study, though I don't believe that there was current gender identity available in this data set. So there is a limitation there. But we also saw that there was a higher risk of complications when we looked at this national or the state level data, that there were 4 times higher the risk of multiples in sexual minority women. And this is likely because there are other studies that show if you use medication in someone who doesn't have infertility, you're not necessarily increasing the chance of success of pregnancy, but you may just be increasing the risk of multiples. So that's why, for example, in my clinic, I often will offer an unmedicated, unmonitored insemination cycle. Like I don't need to give you extra medicine that you don't need. But this paper was really looking at contemporary cohorts, and it really kind of got me asking, was this always the case? And I don't want to spend too much time going through these cohorts that I used, but I did just wanted to highlight that we looked at a historical cohort using data from a nurses' health study, and we actually found that in births that primarily took place in the 1980s, the risk of multiple birth, and I'll show this here, when looking specifically at lesbian participants, was 2.7 times higher than in heterosexual participants. So even though the field of fertility has changed dramatically in those decades in between the 80s and today, we actually see that this elevated risk of multiples has actually persisted for many years. And we've really just kind of only recently kind of started talking about it as a medical community and being aware of it. And this is different than, maybe a patient that comes in requesting this. This is kind of like, we see this regardless of what the patient is kind of requesting. This is just an elevation at a population level. And so other things that I kind of want to mention is that this work really only focused on individuals, and we only had data on sexual orientation. So something that we're working on is we want to have information about current partner sex and gender identity. And so we actually do have a separate study that was actually able to look at the use of medically assisted reproduction, not just based on sexual orientation, but we were actually able to get a level of granularity of, so if you identify as this sexual orientation, what does your partner identify with? What is that partner's reproductive organ inventory, and what is yours? And really kind of start crystallizing what we're really getting at. Because I think a lot of times what we do in our community of research is we might say that we're studying quote unquote lesbians, but maybe we didn't even ask the patient that. Maybe an assumption was made in the medical record, or maybe they identify as lesbian, but they actually had a partner that produced sperm. And so we're not studying the patient population that we really think we are. So this was a paper that we really wanted to just show to researchers and other clinicians. You really have to clearly define how you characterize a patient population. And if you made assumptions, which sometimes, unfortunately, you do have to do in research, you have to acknowledge that an assumption was made and that you might have made the wrong assumption. And so we're really kind of trying to be more thoughtful about that in future studies. And so when we kind of think about other communities that have not really been included, gender diverse folks and transgender assigned female at birth is another group that often isn't included in research. And so one of the main things that my research has started to focus on is because we know that cost is one of the largest barriers for this patient population, I started thinking about, well, what are some ways that we could study this patient population if they can't usually afford to come to a fertility clinic? And so what I did is I partnered with a fertility benefits company called Progeny, and we are fortunate to be kind of in the Bay Area where there are a lot of companies that actually kind of recruit talent by having better benefits. And so Progeny is one of those places that actually has inclusive benefits for LGBTQ family building, including for transmasculine patients that want to freeze their eggs. And so we did a small study where we actually looked, and this is probably going to come across as a no-brainer, but in patients that had inclusive benefits, almost 90% of them actually went ahead with treatment. So 6 of them did IVF, 7 of them froze eggs, 2 of them pursued inseminations, and only 2 of them decided not to go through with treatment. And I can tell you anecdotally, 90% of the patients that I see do not actually go through with treatment. Most of them come to see me and they say, I really wish that I could do this, but I can't afford it. And so this was just a way to kind of say, look, if we cover these things, these are services that our patients want. And so patients aren't doing it not because they don't want to, but because they can't afford it. A little outside of the scope of today's talk, but I did just want to kind of say that because we did have information on the IVF and the egg freezing, I wanted to talk a little bit about that. So when we think about egg biology, I think it's important to realize that someone who is born with ovaries, typically this is an XX individual, but not always. So someone who is born with ovaries that produce eggs, they're actually going to have about 10 million eggs before they're even born. By the time they're born, that number is down to about 1 million. By the time they reach puberty, we're talking about hundreds of thousands of eggs. And then we actually have the most fertile decade of life being the 3rd decade of life, with a fertility decline happening in kind of the late 30s. There's really no magic number. And then the average age of menopause being around the age of 51. So why this is important is because biology doesn't kind of pick and choose based on sexual orientation. So the reality is, regardless of orientation, an individual that has eggs, that number is going to decline throughout life, no matter what they're doing, no matter if they're on hormonal medications for a variety of reasons, no matter if they had a pregnancy in the past, it doesn't really matter. Fertility decline will happen just kind of in everyone. And so on an individual level, ways that we usually kind of assess that is we can do a blood test called an AMH that actually can help us predict where someone might fall on this line, because not everyone is going to be exactly this kind of, neat picture on a graph. The other thing that we can do is we can actually do an ultrasound and we can count the number of follicles, which is where eggs live in an ovary, and get a sense on the combination of the blood work and the follicle count, where does someone fall on this line, and help us decide what kind of treatment they need. So let's just say that we decided that they need IVF or the patient's requesting IVF, just to kind of give you a sense of what that looks like. And I do just also want to acknowledge I'm using a lot of medical jargon and terminology. I appreciate that not everyone uses the same terminology, but just because this is a medical talk, I'm default going to be using some words that may be triggering for some folks. But so this process of IVF is typically involving what's called a transvaginal ultrasound that is placed in the vagina or in the front genital opening so that we can actually take pictures of the ovaries. And there's actually the ability on certain ultrasound probes to attach a needle so you can actually put the needle into the ovary and bring the egg out. And you actually do that for each individual follicle. And once you do that, you can then either freeze those eggs or you can put them in a petri dish and expose them to sperm to make embryos in the lab. And then you can put them back either in the same patient's embryo uterus or in a partner's uterus or in a gestational carrier or surrogate's uterus through a catheter and a transfer. So that's just kind of to give a general overview of what that process looks like. One thing that I'm going to kind of just go over quickly, in our small study, we did look at clinical outcomes in folks before they started testosterone, in folks after they started testosterone. We also looked in folks who didn't stop testosterone at all. We looked at individuals who did stop, but they only stopped it briefly, or they stopped it for a longer period of time. And all of that is to say, overall, it appears that regardless of what you do with gender-affirming hormone therapy, we appear to be getting reassuring outcomes in the number of eggs and in the number of eggs that are usable for future fertilization. But I do want to put a cautionary tale here there hasn't really been a lot of research on long-term outcomes. So whether or not those eggs will be fertilized to become high-quality embryos that will then become a high-quality pregnancy, we don't have a lot of great data on that yet, but what early data we have is reassuring. We did have one patient in this study who did make embryos, and even though they had actually a low number of eggs, they had a really good fertilization rate, and they also had a good number of embryos, and 2 of them were genetically normal. Again, reassuring, but that's one person, so it's kind of hard to counsel patients based on that. So that kind of brings us to this next question of, how do we get more data or larger sample sizes? And so kind of a next step that we're in the process of doing is I've partnered with the University of Michigan, and we're actually creating a database that's going to track outcomes in transmasculine folks on a national level. So I say we're partnering with Michigan, but we're also going to partner with other individuals. The data is just going to live at Michigan, but other universities are going to join us, and we're going to track outcomes at each of these different places so that we can counsel our patients better. And I think all of that really was kind of focused on a population that was assigned female at birth. And so I do also just want to acknowledge that folks that are assigned male at birth also come to a fertility clinic. And this is another community that's really been left out of the literature. And most reproductive health research has focused on sexually transmitted infections, particularly HIV. And there's really been not a lot of research on reproduction for same-sex male couples or larger relationships. And so another thing that I want to highlight is that this is actually a community that is still turned away from fertility centers, actually more than any other community. So even more than some of our gender minority patients as well. The exception might be gender minority folks that are assigned male at birth, largely because they often get services directly from a sperm bank and they can actually bypass a clinic. But at my clinic, for example, we still welcome those patients for counseling and to discuss options, because it can be very overwhelming, especially for a pediatric patient, to just kind of like say to them, oh, just go to the bank and they'll figure it out. I think it's really helpful to kind of see a doctor, talk about your options, and come up with a plan. But for those that are cisgender assigned male at birth, in general, just to kind of talk about these patients, we took a similar approach and we looked at inclusive benefits with that company, Progeny. And we actually wanted to just start describing kind of some clinical trends, some patterns. And what we saw was that in same-sex male couples, we usually see that both of them would like to be a sperm source. Most of them are using genetic testing. Most of them are doing single embryo transfers, but about 26% were having more than one embryo put back in, which really is not the standard of care. That number should really approach 0. But most of the time it resulted in a singleton, one pregnancy, and the live birth rate was really exceptionally high. And we usually don't see success rates that high, but when you think about a same-sex male couple that presents to a fertility clinic, they have 2 sperm sources to choose from. They're usually using a young egg donor, and they're also usually using someone who has a uterus who's already had a pregnancy that was healthy and successful. So we see very high success rates in this population. And I actually think this population is really kind of the gold standard of a fertility clinic. So even if you're not in a same-sex male couple, if you're, for example, let's say you're a single individual that's assigned female at birth, or in a lesbian, 2 same-sex egg-producing individuals, you still might want to know how successful is a same-sex male couple at a fertility clinic, because that's really the highest level of success that a fertility clinic can achieve, because they have all of the kind of ideal ingredients in the lab. So I think it's still a helpful metric, and it's kind of like queer reproduction informing for each of the different communities. We can learn from experiences from everyone in the clinic. I'm going to kind of go through this next part to make sure that I have time for questions. I did want to highlight that we are currently doing a larger national study in same-sex male couples. That's going to be the largest study ever published. I just got back from Amsterdam, where I presented these findings. Was really well received by that community. And I'll be presenting the findings in Denver this fall at the American Society for Reproductive Medicine. And so this will be kind of the first time that national data has ever been collected in same-sex male couples that present to a fertility clinic. Other things that I wanted to talk about are I think maybe just kind of to highlight, because I think it's interesting. So for the geographic distribution of same-sex male intended parents, we're seeing that they're actually getting treatment all over the country, including in places that you might not necessarily expect. So California maybe is obvious. New York is maybe obvious, though actually maybe it shouldn't be obvious because gestational carrier or surrogacy was actually illegal in New York until a couple of years ago, but it was still being done. And then Texas actually is another one of the really big contributors. And that's really not because Texas is super known for its inclusive reproductive rights, but Texas is a really pro-industry state. So they're really supportive of the gestational carrier industry from the perspective of there are companies that are kind of doing these services. And so it's important for really all LGBTQ individuals to check local regulations and laws because they can vary, very drastically depending on what you're going to do, whether or not you're kind of having a gestating parent or not, whether or not you're doing second parent adoption, whether or not you're using a surrogate, whether or not you need to have a doctor or a midwife perform your insemination, because maybe if you don't have a clinician there, it might not be recognized on the birth certificate. So you really have to kind of check all these local laws. The other thing that was really interesting that I think, unless folks are interested, I won't spend too much time talking about this, but in the national database that I used, 50% of the same-sex male couples that were building their families in the United States were actually from other countries flying to the United States. And so this is interesting because I think in the lay media, we often think of people flying to historically Thailand or India because it's cheaper to have a surrogate and kind of to go through the process there. But the reality is for same-sex male couples all over the world, many countries, it's either illegal for them to do this process or it's illegal for everyone to do this process. So the country might not allow surrogates at all. So what's actually happening is that people are flying to the United States for this care. And actually, most of them are actually flying specifically to California for this care. So just kind of an interesting piece of information. And there were about 23 different European countries represented in our data set. Kind of next topic, we just finished actually a series of semi-structured interviews with same-sex male couples. So that's another study that's going to be coming out shortly, where we talk about the logistics of sperm use, the motivations for genetic testing, why they do single versus double embryo transfer, and characteristics that they're looking for in an egg donor. And then kind of going on to the next kind of step, which is really going to be the kind of the focus of my career, which is starting the Q+ family building clinical research program at Stanford University. And so this is going to be an ability to kind of combine the work that I've done, the work that I'm doing, and the work that I want to do in the future, where we're actually going to follow the outcomes for both assigned male at birth and assigned female at birth populations, both sexual minorities and gender minorities, to really kind of learn more about family building and all the different pathways for these communities. And so this is a clinic that really leveraged a lot of support from the Children's Hospital. And so we were able to hire a specialized team that's entirely dedicated to queer family building. So I myself am the medical director. I have a physician assistant, a nurse, a mental health clinician, and a patient care coordinator. And we'll also be hiring some research support staff. And our goals are really to kind of improve sexual orientation and gender identity data collection, and also to continue to work on expanding clinical services for all LGBTQ patients. So some things that we've been trying to do, unfortunately, Stanford is a very expensive place to get care if you don't have insurance through them, and even then it can still be expensive. So we're trying to work with other providers to come up with protocols where we can use cheaper medications when medications are needed, to modify protocols using either no medications or lower doses of medications, decreasing the amount of blood work or ultrasounds that are needed. And then we also started using InvoCell, which is an FDA-approved vaginal incubator, where you can actually put the eggs and a sperm in a device that's placed vaginally. And so you can actually take out the cost of the IVF lab by having someone actually gestate in that very early stage using this vaginal incubator. And so I actually flew to Birmingham, Alabama to learn how to do this at a low-cost clinic there because I wanted to bring that back so that I could offer it to my patients here. We also have some other discount programs. So similar to fertility preservation with patients with cancer, we're trying to enact a program where, particularly for our young pediatric transgender patients that would like to freeze eggs or sperm before starting gender affirming hormone therapy, if they're cash pay, we give them a discount because it's just so cost prohibitive otherwise. And I'm still advocating, haven't been successful yet at trying to get some bundled pricing. So right now, everything is kind of a la carte. So each time you need an ultrasound, each time you need blood work, I'm trying to get kind of a packaged deal so that can be more affordable. Um, Other things that we've been trying to do is work with some community partnerships. So I often will refer my patients to a nurse midwife. So they might kind of come to see me and they're like, your clinic sounds great, but actually this still feels too medical for what I'm looking for. And so I kind of can refer them to a midwife who can do a home-based insemination. And this has really worked well bi-directionally because then those midwives will often refer patients to me that they're like, hey, I've been trying to get this patient pregnant with home inseminations for a year and it hasn't been successful. Do you mind doing like an additional workup? So that's been nice to have that kind of bi-directional ability. We work with the Sperm Bank of California to help offer cheaper sperm storage and sperm freezing for our transgender patients. And we also work with Reprotech for long-term storage. So it can be about $1,000 a year to store reproductive material at a clinic. And so we partner with Reprotech to kind of offer a lower cost alternative for long-term storage. I also kind of not really related, but I think there is an important history there. Stanford historically did not care for HIV positive patients at the fertility clinic. And so I changed that policy last year. And so I now accept HIV positive patients. And we also store their material also with Reprotech because they offer a discount program for that as well. And then we're also part of the Rainbow Chamber of Commerce in Silicon Valley. And we're hoping in the future to work with our community engagement team at Stanford to create a patient advisory board. And we'd also like to do some more outreach to the LGBTQ centers in the area. So this is kind of things that are on the docket that we quite haven't done yet, but that's kind of looking forward. Some things that I just want to mention in case folks aren't aware. The American Society for Reproductive Medicine did release a new definition of infertility. I know that can be a stigmatizing word and it might not be a word that everyone kind of self-identifies with, but from the perspective of a clinician, like as a doctor, I'm really excited by this because the new definition includes people using donor material. And so why that's important is that I can say to your insurance company that someone who's coming to me using donor sperm is in fact infertile, according to the American Society for Reproductive Medicine. And then if they don't give you infertility coverage the way that they give to their other parent patients, they can then be sued for discrimination. So this is a way to actually, it was a way to advocate for us to get benefits, even if it's not necessarily the terminology that we would choose. And there was actually a recent class action lawsuit that I don't know how many of the details that I can share, but we're going to see a lot of changes for folks getting more coverage, particularly those with Aetna, as a result of that lawsuit. And I was really happy to be a part of that to kind of make those changes. At Stanford in particular, we also have some hospital committees that are always trying to kind of improve. And we are hoping to partner more with the law school to really think about how different laws, not just in California, but around the world, might impact the ability to get care in the LGBT community for family building. For teaching, just in case folks are interested. So I have a medical student that rotates with me. They usually come twice a month. I also train residents and fellows, and then I teach in several classes in the undergraduate, the graduate, and the School of Medicine. And so I share this because I think it's exciting. Like I think back, I'm like, I can't imagine if when I was in college, someone gave me a lecture on queer reproduction. So I'm just excited that like I have the platform to do this. And folks get to learn about this. And then maybe they'll decide that they want to go into this field too and provide this care. And then we are hoping to actually in the future, it's not going to happen this year as we thought, but hopefully next year, we're going to try to start having our medical students have a patient panel where LGBTQ patients come and share their experiences with the medical community and how it was like to build their family. Because I think those were some of the most informative things that I had in medical school when I actually had the opportunity to talk to patients about their experiences. In terms of some clinical guidelines, the American Society for Reproductive Medicine, this says summer 2024 because that was the goal. But I'm hoping winter of 2024, maybe 2025, they'll finally be out. We've written them, they're just under review. So for the first time ever, there's going to be guidelines for LGBTQ family building that doctors can kind of use. I also just went to Charleston this spring and I presented at the donor egg meeting, and there was a whole day dedicated to LGBTQ family building. And this was a group of, it had people that work at surrogacy agencies, it had nurses that work in FDA settings, and it had just a really diverse group of people who all wanted to learn more. And so that's really just, we're trying to spread this knowledge and kind of help people get more cultural competence. And maybe more important than competence is kind of cultural humility about this topic and kind of just learning as much as they can. And then one day we're hoping to host a conference here at Stanford where people can travel from all around the world to learn about LGBTQ family building. I've already talked a lot about my research today, so I don't think that I'm going to go too much into this, but I do just want to mention that, it's not just our team at Stanford. A lot of my research has involved a lot of different collaborators at other places. So there are people that are doing research related to this everywhere, and it's really it's being recognized as an important area. So I'm just excited about that. I kind of mentioned this earlier, so I just kind of presented our work in Amsterdam, and I think the European Society is also interested in kind of increasing their programming around LGBTQ family building. Coming up in Denver in October, there's going to be a whole talk dedicated to reciprocal IVF, and I invited Pedro to actually come over from Portugal for that talk. So excited to have him here. And then men having babies, they just got a patient advocacy grant. So they're going to be doing some more work particularly with same-sex male couples and building their families. And we're going to be partnering with Born Ontario, which is actually Canada's population database for fertility care, to do some studies in that database in addition to the work that I've done in the American systems. Not going to focus too much on industry partnerships. And then I will just also put a plug if folks are interested. So there is an area called in vitro gametogenesis, which is really the holy grail of queer reproduction. And so this would be the ability to create eggs and sperm in the lab. And so you could actually take a skin cell from your arm and make an egg or a sperm. And so this is really going to revolutionize reproduction, particularly same-sex reproduction. And, when I was in undergraduate, I was interested in this, but it was like very sci-fi, like it felt like Gattaca, but this is going to happen in the next 10 years. It'll be clinically available, maybe 15. But so we're going to see this in our lifetime. And so I think this is kind of an exciting area to keep a lookout for. And there's a company here in the Bay Area that works on this. They were recently featured in NPR. And then the Oregon Health Sciences University actually got a large grant to study this. They have more permissive regulations to do this type of research, even more permissive than the state of California. So just a couple disclosures. A lot of the things I mentioned today are only possible through funding through a lot of different sources. And so I just wanted to put those here and kind of give a plug. And then also, cheesy, but it's true, it takes a village. A lot of my work is because I've had collaborators that have really supported me to do this. And so I just want to kind of give them each a plug. And then also just acknowledge my Q+ team, my division. We have a gender clinic at Stanford that's been really great for gender affirming hormone care, and we get a lot of referrals from there. We also have the LGBTQ health program, which does kind of other medicine and coordination of care. Blaise Bush is our amazing executive director. And then the Stanford Children's Hospital Executive Committee, and just very supportive that they took a chance on my program and kind of let us hire a team dedicated to this. And this was just me and some of my team members. We were presented with a ball at the the Stanford basketball game for our work in LGBTQ health.
Thank you so much, Brent. This was so awesome. I'm excited to include this in the community. I will send everyone the recording. So if you're not yet part of the Pregnant Together community, I'll email you this recording and a little more information on how to join. And yeah, so grateful that you're doing this work and advocating for our communities, and excited to see as the Q Plus clinic grows and grow this whole community of queer families.
Yeah, thanks so much. Thank you for having me.
Yeah, thanks, guys.